Good morning, everyone. I can see people are still entering the meeting, but welcome to this session, delivering on the shift to prevention in the NHS. Really delighted you could join us today. For those just entering now, gosh, there's lots of interest and lots of people joining, which is wonderful. So, as I say, welcome to this webinar, delivering on the shift to prevention in the NHS. I'm Sarah Woolnough. I'm the Chief Executive of the King's Fund. I'm a previous trustee of ASH and spent many years at Cancer Research UK and have done some work on tobacco control in the past. So delighted to be chairing this session. We've got an absolutely brilliant lineup of speakers, and then we will make sure we've got time for Q&A towards the end of the session. I think if we could just move on, we've got a housekeeping slide that I need to draw your attention to. Here we go. So yeah, if you could keep yourself muted and not turn on your video unless presenting. Please do submit questions and reflections in the meeting chat, and we'll try to draw on as many of those comments in the Q&A. We are also recording the session, and we will share the recorded slides online. And if you have any other issues, please do use the email address on the screen, and we will do our best to help. And if I could have the next slide, please. I think this just shows the agenda. So as you can see, a really fantastic range of speakers. By way of introduction, I wanted to say a couple of things. We have heard a whole range of political and system leaders talking about the importance of the shift to prevention in order to deliver a reimagined health and care system, one that's fit for the population we have today, and this shift being absolutely critical to how we support people to live as well as they might. So it's really high on the political and policy agenda. We obviously await the government's 10-year plan that's going to be published in the next few weeks. But we have seen lots of signs and signals from planning guidance and various other documents out and about, which allude to the importance of the shift. There are, secondly, other moves across government to think about prevention, perhaps some with a bit more energy and momentum behind them than others, but we do have a health mission that the government has set up to think about this broader move towards prevention. And I was up at NHS Confederation last week, as I'm sure several of you on this call was. And actually throughout the couple of days, there were lots of sessions really talking about how we bring the shift to life. So not only sickness to prevention, but also hospital to community is another example. And there seems to be such energy and enthusiasm for the how. How do we do this? How do we make faster progress towards this shift? And that's the context in which we are pulling the webinar together today, an opportunity to reflect on how we can make this shift happen in practice, building on what has already been achieved and with a particular focus on tobacco as a case study. So without further ado, I'd like to welcome our first speaker presenter, Sir Jim Mackey. Sir Jim, of course, is the new Chief Executive of NHS England since April. We're really delighted, Jim, that you've made time to join us so early in your tenure and give a few minutes to talk to us about the shift to prevention. Over to you.
Thanks, Sarah, and great to see so many on the call, just over 400 on the call, which is fantastic. And as you've just said, there is a lot of focus on this now. There's a lot of energy, there's a lot of enthusiasm, but there's also a lot of anxiety as well about we've got a lot of change going on, and also just how do we actually bring this to life and make sure it's not just something we all talk about, which is what we're really all very interested in. Next slide, please. It has already been said, so we've got a lot going on in the service generally at the moment. When I agreed to take on this role and help through this period with other colleagues who joined the national team, there are a few things that were talked about last week that are really important about the rules and creating the conditions for success, working differently and better together, and also that whole ambition thing. So we're focused on that. We've largely delivered the 100-day plan. There's a couple of things that we're still struggling with, but we'll get them resolved the next few weeks. And working on now also the next phase after that, navigating summer, but also then getting into the kind of pre-winter phase. But post 10-year plan, being very clear how we'll bring the plan to life, engaging with the service immediately from publication in July on the delivery of all of the key parts of the plan. And I still think when people read it, they'll produce a lot of energy, especially around prevention. And linked to that, still think one of the best bits is going to be the neighbourhood care model. We've got a financial settlement as well that we should just acknowledge and recognise is a huge amount of money by any standards. It's never enough for what we want to deliver and to deliver all of the ambition, etc. But everyone's aware about where we are as a country and the international position, etc. So I do think we've got as much as can be given to us. And if we're honest, we haven't made good use of the money over the last several years as well. So we do have a bit to do ourselves to get better value. In that challenge, when people are talking to me about how do we get the space for prevention, how do we invest in prevention, etc., you all know as well as I do that relatively small sums in the scheme of things can make a huge impact from a prevention perspective. So we've just got to really back ourselves on that, help with the maths, make sure we're learning from each other, and take some gambles with all this to do the things that you all want to do, and frankly most people across the NHS and with close partners want to do as well. As I said, hopefully there is a chapter in the plan that's about prevention in the neighbourhood health service initiative and movement, etc. will also help bring this to life also. Next slide, please. To help enable this, we have made quite a big shift in the role and focus of ICBs so far. So we've got a long way in the last few weeks about refocusing the role more as in strategic commissioning, much clearer focus on the leader on population health and prevention in local systems as well. And that'll move quite quickly now through the summer and into the autumn. We're going into next year, we'll be expecting to see commissioning decisions starting to take place, start getting this thing powered up and more structured and more organised, etc. as well. Again, with discussion with ICB colleagues, there's a lot of enthusiasm about that. There's obviously concern about the whole change process generally, but this is one aspect that people are very, very interested in. And as we all know, again, we've got to carry local partners with us, work effectively, especially with local government colleagues as well on this, because it's something we have to do genuinely as partners and collaborating together. Next slide, please. And I think in this, again, which we'll hopefully see reinforced in the plan, but certainly in the steps after the plan, that this is about every part of the service pulling together and doing its bits. So it's not entirely the domain of one part of the system over another. Clearly it's going to be led by ICBs, but I would have always seen in my job as a trust chief exec that there were bits of this, parts of this I really need to play my part in. Some bits I had to deliver directly, but generally as a priority area, something I had to really invest time in, invest leadership commitment and capital into, etc. And hopefully you'll see there in the box on the right some steps already where we've been doing things over the last few months as well, where it's not the case that nothing is happening. I think this just really is about getting more organised, more focused, more structured, and ramping up delivery on the things that we all know are going to count. Next slide, please. I know from discussion with Ailsa and some other colleagues on the call here over recent weeks, there is some anxiety about the changes and certainly the financial squeeze and what that's doing for commissioning of services around specifically smoking and tobacco cessation, and also alcohol in different parts of the country. So we all know these things are important to stay focused on also. So we need to make sure that we don't have any damage done in this churn. We retain the focus. We make sure things move from being maybe not quite commissioned or vaguely commissioned into something that's a bit more structured into the new world. And again, I think remembering the maths here is helpful as well as the people side of it. I think that we're all interested in. But when you look at how the maths works on some of this, as described in the middle of this slide, there's some really powerful statistics as well that can help with the decision making. And I think that's it from the slide. So all I would say, just in addition to that, is just that I'm really committed to this. National execs, DHSE colleagues are really committed to this. So we do accept and understand it's a very turbulent time with a lot of risk. We'll turn a lot of things on the head. If we can stay with this, which I'm sure we will do, you see the plan, start seeing the changes happening in the autumn to bring the plan to life. Next year we can be in a much better place on delivering the things that you all want to deliver, and where the evidence really shows it works, which is, I think, where we really need to go. So happy to stop there and hand over to the next speaker, if that's okay.
Jim, thank you. That was great. And I'm sure, the points you make, well, the honesty, firstly, thank you, because there's obviously a lot going on across the system, and sort of recognising in times of churn the importance of churn and change, the importance of keeping focused on where the evidence leads us, and backing ourselves is really great to hear you reflect on. Thank you. We will return, I'm sure, in the Q&A, but for now, thank you. And I'm delighted to welcome Dr Chris Weiner, Chief Medical Officer at Derby and Derbyshire ICB. As Medical Director, Chris supports the development and delivery of the ICB, of course, and Chris will be talking today about how the commitment to tobacco dependence treatment services fits with the ICB's current and future strategy. Chris, delighted you could join us. Over to you.
Thank you. Look, good morning, everybody. Yesterday, I was trying to work out what kind of angle to take on the conversation here today. I always like to give a slightly different angle just to get people thinking differently about services. And whilst I was thinking, our Category 2 ambulance response times for Derby and Derbyshire came in from over the weekend, and they were at 39 minutes. This means that it takes 39 minutes for us to reach people experiencing a potential heart attack or stroke. It's an important number. And so I thought, right, okay, it's important. Let's start there then. So when I was a junior doctor, we often spoke about the golden hour, the first hour in a person's health crisis, that it is crucial in determining their health outcomes. And yesterday we were spending the first 39 minutes of that hour just trying to get an ambulance to those people in need. Why? Because we are struggling to maintain flow through our hospitals and allow our ambulances to get back on the road as quickly as we would like. So, look, I'm Chris Weiner. I'm the Chief Medical Officer at Derby and Derbyshire ICB. My role is to improve the health outcomes for the community in Derby and Derbyshire through the coordinated actions of the NHS, the wider statutory sector, and also the voluntary sector. The services that we commission are vital in doing this. And in my opinion, prevention services have never been more important, valuable, and needed than they are now. Every 5 minutes or so, someone in the UK is admitted to hospital with a smoking-related illness. In Derbyshire, we witness this reality daily in our emergency departments, our surgical and medical wards, and our maternity departments. Smoking is the leading cause of preventable illness and death in the UK, and our hospital beds and healthcare system are filled with people because of smoking. The delivery of smoking cessation services across ICBs, such as Derby and Derbyshire, isn't just a good idea for our moral well-being. It's actually a clinical performance, and an economic imperative. If we want to improve our ambulance turnaround times, enhance our cancer care, deliver more effective elective healthcare, achieve better health outcomes, and reduce cost, then we must reduce our bed occupancy and improve flow through our urgent and emergency healthcare system. Tobacco control and smoking cessation are arguably the two most important evidence-based areas of prevention that will allow us to do this. Now, tobacco drives health inequalities, burdens our hospitals and social care, and shortens lives. It causes around 1 in 4 of all UK cancer deaths, respiratory disease, premature heart disease, stroke, heart failure, the list goes on and on. It is a significant risk factor also at the other end of life, with poor maternal and infant outcomes, increasing the chances of intrauterine growth retardation, stillbirth, and outcomes such as sudden infant death. Smoking is responsible for half of the difference in life expectancy between the least and the most deprived communities. And in Derby and Derbyshire, we still have around about 47,500 smokers in our 2 most deprived deciles, and that compares with about 13,500 smokers in our 2 richest deciles. And it is the poorest communities that we serve that have the highest rates of COPD, stroke, and premature death from all causes. There is a clear business case in my mind for action on smoking across Derby and Derbyshire. Smoking costs our NHS, my NHS, around about £47 million per annum. And in 2017 to 2019, it resulted in 10,500 hospital admissions and used 99,000 bed days. It also caused 4,000 smoking attributable deaths in just 1 year. The financial return on the investment from smoking cessation and tobacco control is absolutely clear. £15.30 for every £1 spent over the course of 5 years. The human return is even greater. Longer lives, healthier families, and fairer futures. So what we've done, here's what we've done in Derby and Derbyshire, and we must continue to build on. We have used the hard evidence base, and we have protected our tobacco dependency treatment resources through the financial planning rounds for 25-26. In the previous year, we've managed to expand our support into mental health and maternity services, and we've secured NHSE funding to pilot smoking cessation services in the emergency department at University Hospital Derby and Burton. We've had over 6,000 inpatients and 1,000 maternity clients referred through to our tobacco dependency treatment services last year. And for those people that actually take up the service, we had a 50% quit rate achieved at 4 weeks. All of that's pretty good. We should be proud of that, I suspect, but actually, it's not good enough. By our own local definitions, we've put in place a bronze level service today, and we really want to go for gold. We still need to grow our tobacco control and smoking cessation services, and we now need to use population health management to target our smoking cessation services at those people most likely to run into health problems in the next year and the year after. We want to run tobacco dependency services alongside other preventative and rehabilitation programs tackling respiratory disease, hypertension, cardiovascular disease, obesity, diabetes, stroke, renal disease, and mental health. And in doing this, we want to optimize the benefits of all of those preventative activities. We now need to use population health management to shape the neighbourhood health models so that we have programs that are culturally sensitive, effective, and engage with the local communities, recognising that the way in which we might configure a service around a Black African community may well be different to how we configure a similar service for an Afro-Caribbean community, or very particular to Derby and Derbyshire, our very large deaf community. We also need population health management to guide investment into our neighbourhoods so that the investment we have is proportionate to the varying need in the individual neighbourhoods themselves. If we do all this, I believe we can maximise the benefits of all our prevention programmes. We can reduce the need for hospital admission. We can reduce the need for social care support and improve the health outcomes for our population, whilst effectively tackling health inequalities. NICE highlights that hospital-based smoking cessation interventions are effective in reducing readmissions alongside improving long-term health outcomes. COPD patients who quit smoking experience a 30 to 50% reduction in admissions within the first year alone. National NHS planning has suggested that expanding pulmonary rehab and smoking cessation services could prevent around about 500,000 exacerbations and avoid 80,000 hospital admissions over 10 years. But I believe we can go further. You know, it's important for us to recognise that we've got things like diabetes, a growing problem for all of us across the country. And according to the National Centre for Smoking Cessation and Training, smoking in people with diabetes is associated with a 35 to 54% greater risk of cardiovascular events and mortality compared to non-smoking diabetic patients. And all of those individuals also have increased risk of nephropathy, neuropathy, retinopathy, coronary heart disease, stroke, and peripheral vascular disease. Fundamentally in the NHS, we have a growing demand problem, and that can only be addressed by a shift to the left in primary or secondary prevention. We need fewer children growing up in smoking households. We need fewer communities where people are admitted unnecessarily with heart attacks, strokes, or COPD because they haven't had those heart attacks or strokes or COPD. And we need our maternity wards to see fewer lower birth weight babies. In Derby and Derbyshire, those 99,000 bed days I mentioned earlier actually probably equate to around about 135 hospital beds. By reducing the number of people using tobacco in the poorest communities locally to the same level as we have in our richest communities, we might expect to reduce our need for those beds by around about 70. Now, I know there will be naysayers who will respond, well, you know, you won't actually be able to close those beds, will you? And so what's the point in doing that? But I also know that the availability of those beds can reduce bed occupancy in hospitals to a level where we can start to turn ambulances around far more quickly. And there's a hell of a lot of value in that. Population health management can facilitate us in delivering on all of this and allow us to manage better the health services we have today. We can join up data sets across primary and secondary care, identify those who are at highest risk of disease and hospital admission, and then target tobacco control interventions at those people who can benefit from those interventions alongside other preventative measures, such as the soups and shakes programme or the health check programmes. You know, today, tobacco control and treatment is much more than just a focus on lung cancer, COPD, and heart disease. It's about good treatment outcomes for people with diabetes, renal disease, neurological disease, pregnancy, and a whole host of other conditions. It's about good health outcomes for people in our poorest communities and also our most vulnerable children. It's about ensuring that we can maintain flow through our urgent and emergency care system by preventing unnecessary admissions. And it is about maintaining performance of our healthcare system so that we can get to people and deliver care to them in their hour of need. Thank you.
Chris, thank you very much. That was a tour de force of, I think, both making a very compelling case for why we need to invest, but really in the context of where we are now with a growing demand problem, with the need to tackle flow. Thank you. That was That was incredibly helpful. I'm going to move us straight on because we want to make sure we've got plenty of time for Q&A. Please keep your comments and questions coming in the chat. I can see it's incredibly rich already, and we'll try to cover as much as we can. But in the meantime, I'd like to welcome Ailsa Rutter, who is the Director of Fresh North East. Ailsa has run a regional programme across the North East for 20 years, delivering faster reductions in smoking than other English regions. Fresh and balance the population health programmes, reducing the harms from tobacco and alcohol across the region, and funded by both the ICB and local government. Ailsa, delighted to have you on this webinar. Over to you.
Thank you very much, Sarah, and what a fantastic speech from Chris. Thank you so much. And I did just want to pay credit to Sir Jim, because when he was the Chief Executive of Northumbria Foundation Trust here in the North East, they really did act as a trailblazer, you know, preempting the long-term plan as such, and that was under Jim's leadership as Chief Executive. I'm here today to represent all of the really equally important parts of the North East system working together to address our biggest driver of health inequalities. If we can go to the next slide, and it was just to kind of explain to you who Fresh is, and I sometimes describe us as a little bit of glue that glues together all of the brilliant parts of the system up here in the North East, whether that's our NHS and our hospital trusts, the really vital role that our directors of public health are playing through the local authorities. But in terms of the Fresh overall programme, we've been running a tobacco control programme comprehensively for 20 years now. We've got multiple strands of work, and all of these are really important. And there isn't one magic solution as to how we're going to end smoking. We do need to make sure that we're being comprehensive, we're being evidence-led, we're learning from each other, and we're collaborating. And, you know, I can't thank enough the ongoing commitment that we have from our ICB here in the region and our 12 local authorities. And this locally together approach has been really important to unite a multiple range of partners under a very clear vision to end smoking. I do want to absolutely pay credit to the other subnational programmes out there, the fantastic work. Often I will say that the North has been doing together in terms of, you know, really buddying up, working together alongside the brilliant team at ASH. But there is absolutely no complacency. And I think a key message here today is, yes, between everybody in this country, we have successfully driven down smoking rates, but there is still loads more to do. And here in the North East, yes, we're down to the second lowest rate in smoking in England, but behind that lies much higher smoking rates in key priority groups, still loads more to be done in terms of SMI, etc. And the next slide just explains to you a little bit of the geography here in the North East. So our ICB is the second largest, the ICS second largest in England. On this next slide, Noah, it does show that the population of the ICS is 3.1 million. So just to explain, the Fresh team hosts the Smoke-Free NHS programme that works across our ICB, two fantastic, incredibly talented people based within our team, and you'll see them at the end on a slide. But we do have a very large ICS geography. We've got 2 mental health trusts, we've got 8 acute trusts and 14 local authorities. And this is about really recognising what's best done at local level, what's best done at regional level. It's about efficiencies, economies of scale. It's about really building up that social movement, that network of peer support, and really trying to ensure that people don't have to reinvent the wheel, etc. On the next slide, you will see that we are really fortunate. We have a very clear vision in the North East North Cumbria. Yes, we are focused upon reducing smoking rates down to 5% by 2030, but ultimately our vision is for a completely smoke-free future, free of the death and disease from tobacco. The distributive leadership in our region has been so incredibly crucial. The fantastic leadership from OHID and Professor Peter Kelly, the former CMO for England, Sir Liam Donaldson, is the chair of our ICB, and the leadership of our directors of public health. And we're very passionate as Fresh to support all parts of the system to end smoking. And we're very clear that if we can end tobacco smoking, this will have the greatest impact to improve the health and well-being and the wealth of our region way more than any other measure. So we really feel this is our very important vision to keep people bonded underneath. On the next slide, this is about working as a system. And at the heart of this is, oh, that's a funny little unhappy looking face, but this organogram that was there on the slide has the person with tobacco dependency at the heart. And what I think we all need to really recognise is that there are many routes to quit. You know, we need to offer people who smoke as many different opportunities, whether that's within the NHS, whether that's through the fantastic work of community stop smoking services, the really unharnessed, I think, key opportunities to tap into primary care more. We've only scratched the surface there, really. But we recognise, so no, I don't know whether the slides have just disappeared at your end, or it's just that I can't see the slides. Can anybody say anything?
I can certainly see them, Ailsa. So some they're coming through. Yeah.
Oh, okay. Well, it's just, I've got them printed in front, so I am. Thank you. Lovely to see the thumbs up. So on this organogram, it's really important, I think, we recognise that the choice of quitting. It's fantastic. We've got many more options now with new medications. We absolutely know that vapes can support adult smokers to successfully quit smoking. But coupled alongside all of this is the wrapping around of broader tobacco control. We're very fortunate, due to the funding in the North East, we're able to deliver mass media quit campaigns, the real, you know, powerful stories of real people who have quit smoking, and the fantastic work of our Smoke Free NHS programme in terms of that workforce plan, the education, the training. And I think what we need to recognise is, you know, to achieve the end to smoking, we need to trigger way more quitting overall. We want to try and get half of all North East smokers making an annual quit attempt, and we do need to increase the overall quit success rate. So there's plans around that. So on the next slide, this is around the role of the Smoke Free NHS programme and the task force. So we're fortunate we've got a task force here in the North East. It was set up in 2017. It predated the long-term plan. And I think our ultimate aim here has been to reframe smoking as a chronic relapsing long-term condition, which requires clinical treatment, and to embed this as a part of core clinical practice for every healthcare professional. It is fantastic to see the progress made across all of the hospital trusts in the North East, the fantastic work of those smoke-free NHS managers, the tobacco dependency treatment services underneath them. The programme is led by a number of really important individuals, all playing a really important role here. And I'm delighted we've got Ruth Sharrick on the call today, who is our ICS clinical lead for tobacco dependency. I've mentioned Rachel and Jojo, who are our strategic manager and project manager, but the leadership within our ICB in terms of really prioritising prevention, whether that's through our prevention board or our directors of public health. So a huge thanks to them. On the next slide, it talks about the enabling work streams and the key pillars that have been in place and will continue to be in place here. And we absolutely recognise there are lots of other places in England that are doing this, and we've learned hugely from the brilliant team, for example, in Greater Manchester and the Cure team there. But it is about communications and consistency in the communications. It's about the regional training, the peer support networks, the work that we're doing with academics in terms of evaluation and focus, the funding and commitment, the fact that we need to modernise. We've had a regional digital support offer. We can see this can really support smokers to quit, and an evidence-led approach to vaping. And we absolutely believe that that has been a key pillar to some of the progress we've made so far. In terms of the numbers, in the North East North Cumbria since 2022 and across all of the clinical pathways in our acute and mental health inpatients and the maternity pathways, it's 51,760 smokers who've been referred to the tobacco dependency treatment services. 36,000 of them have been seen by the teams on the ground, and the fantastic work that they've been doing, the hard work to get these teams set up. And we absolutely know how vital it is that these teams are just now viewed as a clinical must-have, and there should be no hesitancy in terms of their continuation. And on the right of this slide just goes into more detail in terms of some of the deliverables that have been in place. But I'll go to the following slide, please, which is just to say a huge thank you to our ICB, and amongst all of the churn and the other very important priorities that Sir Jim outlined, our ICB has committed the same level of funding this year for the tobacco dependency treatment services, and that's significantly higher than what was in the national allocation for the Smoke-Free NHS programme and for Fresh. And on my last slide, I just wanted to really say this is about ultimately changing lives. It's about real people and the power that we can have as NHS employers, not just for our patients, for our staff. So Carol has hopefully dialed in. Carol was employed as a domestic at Gateshead NHS Trust. She'd smoked since the age of 11. She sadly was diagnosed with mild COPD, but Carol was fortunate to have on her ward Ruth Sharrick, the respiratory consultant, who offered vapes and products to support Carol to quit smoking, which was wonderful. In addition, we had a staff offer, despite it being COVID, across the whole of the North East, to say to NHS staff, we value you, we want you to quit smoking as well. Carol quit after 56 years as a smoker. She is now a phenomenal tobacco dependency treatment advisor. She's really inspiring and motivating and can understand how hard it is to quit. So a huge thank you to Carol. There are thousands of other Carols out there who can really help people to quit. And here is Carol to the right now, you know, with a new lease of life in many ways, and you know, much more physically active. So huge thanks to all of the Carols. And the last slide was just how you could find out more. Thank you.
Ailsa, thank you. That was incredibly powerful. And what I take is a lesson about the power of collaboration, distributive leadership. I think you brought out incredibly powerfully. But of course, this point about there being no room for complacency. And if we tackle tobacco dependency, that will have the greatest impact on improving health. And then really fantastic to understand a bit more about your model and how you've been working and how you've reframed smoking. So thank you. That was fantastic. And also, of course, remembering the human side of this and the power of quitting for people. Okay, last but not least, I'm delighted to welcome Peter Rodderick, who's the Director of Public Health in the City of York. So Peter also, alongside this role, takes a lead amongst a range of DPHs in the ICB for the Centre for Tobacco Control Excellence, and he's worked across the ICB and local government before taking up his current role in York, and was instrumental in the establishment of a comprehensive population health programme on tobacco. Peter, welcome, over to you.
Thanks very much, Sarah, and good afternoon to everyone. So within this presentation, I'm going to give a little bit of a sense of what you've just heard from the North East. The North East, with its Fresh and Balanced programme, is a number of years on from where Humber and North Yorkshire finds itself, but we're very much moulding our programmes in its image and looking to replicate some of the fantastic stuff that have been done. But as well as that, to move us through into thinking a little bit beyond tobacco, because tobacco, in some ways, and smoking cessation offers almost a bit of a playbook for how ICBs can work to improve population health at quite a scale, and how ICBs relate to national bodies and national efforts in terms of prevention and legislation, and down to local areas and teams of public health workers working under directors of public health in local areas, and how those bits of the puzzle fit together. So next slide, please. Going to introduce you to Humber and North Yorkshire ICB. It's the Texas of ICBs. The sun sets 7 minutes earlier in Scarborough on the one side than it does in Hawes on the other side. So it's a very large geographical mix as an ICB, a large coastline, significant rural communities, 2 cities of York and Hull, and a number of large towns such as Grimsby, Scunthorpe, Scarborough, Beverley, a large number of PCNs and acute trusts, 1.7 million people. But just that little circle in the corner to tell you a bit of a story about why we focus on these things from a prevention perspective. We have 4,500 deaths under the age of 75 from preventable causes, essentially things that we know we could have done something about, and stuff to do with the way people live and the conditions they are in lead to those deaths. That was in a 2-year period. We think non-communicable diseases are about 90% of those. So probably around 2,000 people are dying in our area every year from deaths that are just preventable, just considered preventable through what the evidence tells us, and a good proportion of those will come from tobacco, and those deaths which don't come from tobacco will come from unhealthy food or will come from alcohol use. So actually there's a large amount this stress and human misery that is coming from these causes that we wanted to try and tackle as an ICB and as our Directors of Public Health working collaboratively. Next slide, please. So we know that smoking also drives health inequalities, real ranges across our ICB. We have some of the highest rates of smoking in the country for a time period. I think we were points sort of 1, 3 and 4 on the scale of horror just in terms of smoking prevalence, particularly northeast Lincolnshire, Hull and North Lincolnshire with high rates. We know that if you measure our routine and manual occupations smoking rates, that's significantly higher, and even in a place like York, which has low general prevalence, we have 3 or 4 times the prevalence rate in our routine and manual occupations. Next slide, please. Now, we're on the same journey as many other areas in terms of in hospital, maternity and acute and mental health settings, making sure those tobacco dependency treatment services are really embedded within those places. It's not been a ride without its bumps along the road, but we are now at a point where all 9 pathways in 5 trusts have been implemented. We saw in the most recent year a really good sort of follow through from the numbers of people that we're seeing in each setting through into quit dates set and then into quits. We think we've seen over 10,000 people in Humber and North Yorkshire now through these routes, and just looking at the return on investment, and this has been mentioned in other settings, you can demonstrate if you are in 1 year as saving sort of £3 million based on readmission reduction, creating bed spaces, you're saving far more than you ever invest in these types of services. And we've also been highly involved in the National Quality Mark. We're really proud that a couple of our trusts were amongst the first 5 nationally to achieve the status around the quality of their tobacco treatment services. Next slide, please. But we know that this goes beyond what happens in our acute settings. As Ailsa has already mentioned, that actually real emerging evidence that regional coordination around tobacco really reaps dividends. And actually some good work that was published only recently this year and actually made national headlines about the fact that we have seen those northeast and Yorkshire and Humber prevalence rates come down faster than other areas. And the authors of that paper making clear they think regional tobacco control programs really contributed to the process of that faster prevalence reduction across those government office regions. Next slide, please. So what we've done is bring this into what we call the Centre for Excellence in Tobacco Control. This was started a couple of years ago. I started as a consultant in public health working in the ICB in a joint role with a local authority, and it really does have that strong partnership and collaboration at the centre. ICBs cannot do everything in this space. Local authorities cannot do everything in this space. The national government can't do everything in this space. It absolutely has to be a strong collaboration between those 3 levels. And what we have done is put 3 pillars in place for the work that our small team does around the Centre for Excellence, a set of coordination efforts, essentially setting a strategy for population level harm reduction from smoking, a set of effective delivery mechanisms, whether it be integrating smoking cessation into lung health checks, whether it be understanding the illicit market through a big survey, or whether it be campaigns and comms, and then inspiring change to the work we do to filter up international and that legislative piece. Next slide, please. We've also collaborated beyond Humber and North Yorkshire and together have brought our ICB together with West Yorkshire and South Yorkshire. Our local authorities have all added to the pot in terms of funding. So this has become both a local authority public health and an ICB funded programme, delivering a one-stop shop website, some training programmes and particularly mass media. And my next slide talks a little bit about this, particularly our most recent What Will You Miss campaign. And we've done some collaboration, if we can have the next slide, please, and some evaluation on this, and have seen some real impact, particularly in terms of reaching the segments of the market that you need to reach in terms of people most likely to be smokers and most likely to quit smoking. Some bus advertisements, some ITV Channel 4, Sky and Sports advertisement that we've worked on, hundreds of thousands of clips through to our Yes to Quit website, more than 10 million impressions on social media. I mean, this is a lot of data here, isn't it, on reach. I think my key point is, and it's at the bottom here, this kind kind of reach would be impossible for a single local authority. It's only been possible through this kind of regional collaboration. And this is the stuff where you really get into the hearts and the minds of smokers, and you prompt those quit attempts that Ailsa talked about that we want to be each year. The next slide that shows a little bit about some of the evaluation that we've got through, that this is a campaign that's making people stop and think, that's hard hitting. It's not seen as patronising and as inappropriate. It is prompting those quit attempts. Now, to move on to the last couple of slides. You can see here we've had some real success just with that media thing. There is something about just the power of being able to immediately respond to national announcements, being able to practically do work around sort of PR and getting champions and that kind of thing that really grabs the headlines. So we're really pleased with how that has worked out. And the next slide will show you a little bit about that national influence. It was great to be down in Parliament a couple of months ago. I was there with the chair of the Health Select Committee and a number of different politicians and lords, and you can see a couple of our lovely champions there with the great and the good, giving a bit of a sense of what Humber and North Yorkshire is doing in this space. So finally, we're trying to move a little bit beyond or incorporate things beyond tobacco. We're thinking about the role of alcohol, unhealthy foods and gambling. This slide just gives a little bit of sense of the burden of illness which comes from those areas. We think tobacco gives us a really good playbook to move into this at ICB scale. It doesn't duplicate or overlap what we do from a local authority perspective. Local authority public health teams absolutely have their local leadership in this area, but we think we demonstrate with tobacco a huge amount of value added that we can bring by working at an ICB level, and we're hoping to move that into that area. And the final slide just gives a little bit of sense of what the size of that prize is. We know that actually people who smoke are more likely to have poor diet, to have excessive alcohol consumption, and to be more inactive. And so there is a sense in which it's no good tackling one of these things together. We have to work on multiple risk factors, and we're drawing together what we call a coherent approach for tackling these things across the 6 local authorities within our ICB, and using our ICB as a convening vehicle to help us do that work really well so we can tackle these risk factors and improve the health of our local residents. Thanks, Sarah.
Peter, thank you. Again, that was excellent. Really fantastic to see the power of regional collaboration. Great to actually see some stats about the starkness of the inequalities, which we know exist, but that brought to life. Great to see how you're expanding out beyond tobacco, and the Texas of ICBs is going to stay with me. Thank you, that was brilliant. Right, we've got 11 minutes left for Q&A. If I could invite panelists to come back on, and if we could take the slide, well, perhaps we could take the slide down and then people might be able to see us more easily. The chat has been incredibly busy. And it's really rich, and I know the team at Ash and others will take a really thorough look through comments and come back to you. In the interest of time, I'm going to, and there's lots of different issues raised on the chat, and there's some brilliant examples of work happening, and then there's some worries and concerns. I'm going to group together a few questions to begin if I can. So there's one from Hanan Khan, who talks about a mental health hospital-based tobacco service being at risk of disinvestment due to what the ICB is saying. NHS planning changes. Nationally, there appears to be funding towards tobacco control. It's not always trickling down to the trusts. And in this instance, especially as something that's important as tobacco control within the SMI population, what can we as project managers do to protect these services? And it does play into lots of other comments and questions. For example, from Mark Pearce, unless ICBs are going to be held to account on how they spend their money, cash strapped and on prevention and tobacco control, cash strapped systems are going to look to make savings. Another question, what accountability do ICBs have when they choose not to allocate funds for prevention-based services? So it'd be great to hear, and maybe Jim, if I could come to you first. I mean, you know, this tension that we all know, which is a system that, you know, is under financial pressure, and a philosophy which is we're not going to dictate everything from Whitehall, and we're going to give systems more freedom to respond to local population need. But yet, what do we do if we don't see the investment in areas where, you know, the economic case is strong, the health case is strong? We know these things work.
So this dominates the chat, doesn't it? This concern about things being cut now, but also how do we make sure that ICBs spend appropriately over time. We are trying to move away from too much central direction. So short term, there'll be a bit of let's understand where there's an issue, talk to the ICB, try and prevent damaging things from happening as best we can, build the rules, and then there's a gamble with this, hope that the capacity and capability for strategic commissioning means that this stuff is more centre stage and does get prioritised. I'm naturally anxious about ring fences and tying everybody's hands and being very kind of specific about what should be spent where and for what purpose. And we just had a discussion about this morning. I've lived in an NHS that did that. And you can run the NHS by a spreadsheet nationally. It doesn't mean everything actually works locally. And also what's really powerful in the chat is the amount of very local specific place-based activity and initiative and energy that's going on in here, which I think does work against too much central prescription. So I think we absolutely will hold ICBs to account for how they're spending their money. We'll have to do that short term and making sure there's kind of no damage done when things are in transition. And as we build that commissioning capacity and capability, this has to be centre stage. And again, as a reminder from the points at the beginning, these are relatively small amounts of money in the scheme of the total resource available for an ICB, and dozens of examples in the chat as well about the return on investment and how this is actually good value for money. So it's really, I think, hopefully a tricky period as we navigate the turbulence. As we start next year, there'll be clearer direction. We'll have ICBs more in the new role. We'll be building capacity and capability. I think we've all got to stay with the game and convince everybody as you've done today.
Thank you, Jim. And I know you're going to have to leave us shortly. Incredibly helpful to hear you say those things, absolutely recognising where we are. Really appreciate you joining. I'm going to expand the question out to other panellists. And I think a related question is around staff retention. It's this point of shorter term damage, isn't it? Staff retention, losing good people because of transition, and not being able to bridge contracts. I don't know if any of you would like to come in on this point. Where have you seen things work well? How have you, how have you dealt with some of these issues locally? Peter.
Thank you, Sarah. Well, I think a reflection is if we can't get this right with tobacco, we're going to struggle with many other things. Tobacco is the absolute sort of the barn door obvious thing that this should work in and should pay off the investment to the greatest extent. So we've got to make this work, I think, nationally. And I feel the key word is here patience, and almost the plea for any sort of trust leadership on the call today is about patience. So prevention has always been the thing that we've struggled with nationally, because it's the dog that never barks. You don't see it immediately, but actually it does pay off over the 5 to the 10 year time. These are new services, and introducing new clinical services takes time. It takes time to get staff recruited, it takes time to get the things up and running. It takes time to change culture on wards. Particularly, these services rely on individual wards being able to channel people through to understand what tobacco dependency treatment looks like, to understand NRT and nicotine dependency and all that stuff you need to know. And actually it will take a number of times, and we're perhaps in danger of putting quite a lot of effort in over a sort of 1 to 2 to 3 year cycle for something that would pay off at year 5, 6 and 7, and then dismantling it because we haven't immediately seen a change in flow and haven't immediately released that cash out. I think we absolutely have to think about the patient sort of 5-year plan for this and invest accordingly, because the evidence is very clear. Ottawa showed us, other trusts even in UK have now started to show us, you do start to see those massive reductions in bed days. You do start to see a real change in the system, but it takes a little bit longer than an overnight sort of switch it on type approach.
Thank you. The importance of patience, incredibly helpful point to make. Ailsa.
Yeah, I was just completely agree with everything Peter said. I think the importance of using your successful quitter case studies as well to really bring it to life, but also really important is the recognition of the role of our advisors and how fantastic they are. So here in the Northeast, we have a COI, Joanna Feeney runs that, and we now have quitter of the quarter, team of the quarter, advisor of the quarter, because what we really want to do is build up the profile. This is the most vital key professional group. We want people to feel attracted to want to apply for these jobs. But I also want to say I'm a nurse by background, but a very long time ago. And not once during my training did anybody ever talk to me about what do you do about tobacco dependency. So I felt pretty helpless, if I'm honest. So I also think it'd be fantastic to think about how do we have all medical directors and sounding like Chris. And also, you know, so actually I think we also need to be thinking for the future of the NHS, let's influence the training so that when people are coming out and they're qualified as nurses and physios and midwives and doctors, they know what to do about this, rather than years into your career we're trying to train people. But I did just want to say, I think the more recognition we can give and to bring to life how vital the Carols of the world are and the Ruths of the world and the Chris's of the world, the better.
Thank you. We are nearly at time, but I'm going to come back to panelists one more time to ask you to give a reflection about the key opportunity for the future. And I want to do justice to the chat, which is, you know, I mean, I leave this webinar feeling a mix of emotions, partly this incredibly powerful reminder amongst a brilliant community of the power of tobacco control and delivering what we know works, and that being, you know, so important for people and the health of the nation, but also really conscious of the short-term challenges. And I don't want to you know, not do that issue justice. But to each of you, and perhaps Chris, if I could come to you first, just one reflection, what for the future that we can hold on to as we leave the webinar.
Okay, thank you, Sarah. I think my reflection is I'm a public health practitioner by background. That's what I was trained in. And when I started public health 27 years ago, people used to talk about the investment for the long term, and they were talking about prevention for 25 years down the line. We've heard Peter talk about that prevention delivering in up to around about 5 years, but don't forget that actually some of this prevention agenda delivers far, far quicker. And I remind you to what I was saying around COPD and the reduction in in-year admissions if we manage to stop people with COPD from smoking. Now, those are real numbers which help solve the problems today, but people need to be reminded that this is not all about delivering health outcomes, health improvement 5, 10, 15, 20 years down the line. It's about delivering it now as well.
Thank you. Peter, very briefly.
Yeah, thank you. Well, I think just for me, the reflection is on the local, the regional and the national. All three have their place to play in this agenda. And I think the danger is they all duplicate and do the same thing. The risk is that one tier is missing, but the golden sweet thing is that they all sort of sing the right bit of the hymn sheet, and together, I think when that happens, when you get a national policy direction that's supportive, something like Fresh or Balance in the Northeast region that coordinates and acts as the glue, and local directors of public health working in this, I think you get incredible results. I think we've shown that through some of the stats today.
Thank you. Final word, Ailsa.
Have a vision. We're going to end smoking. Don't get distracted by other things. Let's remember combustible tobacco products are the key driver of health inequalities. The evidence base is really, really clear. Be very single, you know, just really reiterate it. Don't overcomplicate some of the messages. And the comment about what about children? The most important thing for children is they have their parents and carers around, that they're not dying in their 40s of COPD and the tobacco poverty aspect of it. So yes, this is about a smoke-free future. We can do this. Look at the progress we've made over the last 20 years. So just keep bashing on about it and keep saying to everybody, tobacco is the most important thing tangibly for the NHS to do to tackle health inequalities.
Brilliant note to end. Thank you to the panelists. Thank you to everyone who's joined. Thank you for your comments. I know the ASH team will do their best to come back to answer questions. We really appreciate your time. Keep going, everyone. Thank you.